What, according to you, is the hardest case for new surgeons, even for veterans? What do you think is the hardest case to operate? Is it an intumescent cataract with a Rex's runout situation? Or is it grade 5 cataracts with uncooperative patients? There are a variety of factors that make a case difficult. For me, if you ask me, a case like this, which has a nuclear density of between grade 4 and grade 5, is the most challenging case for surgeons. When you consider a leathery posterior plate, one can easily get stuck up in a situation that gets irreversible and difficult sometimes. So I'll be showing you this case at 1.25x of the normal speed, and better watch out about the tips and tricks I'm going to tell you about this really hard brown cataract with a leathery consistency that fails to chop right away. It will take a lot of time and guts and courage and fine hand-eye coordination on the part of you, just in case if you happen to operate a patient like this by a topical phaco. So I have started the Rexes. As you all know, I want to make a CCC as large as possible and as safely as I can take that Rexes. I'm aiming for a 6.5 to even 7 of Rexes that will aid in these strong separating maneuvers and strong chops that I go ahead with. Direct chop. I'm a big fan of direct chop, as you all know. I don't favor that divide and conquer, those sculpting and drenching techniques that increase your operative time. And I have noticed these non compliant patients, the more your operative time will be, the more non compliant they'll get. So, right at the bat, I'm going to just impale that hard nucleus and the endonucleus by my phaco. Tip number 1, very important, make a big Rexes, as big as you can. Tip number 2, expose your phaco tip really well, about 2 to 3 mm's. Don't underexpose your tip. Yes, tip number 3, impale that endonucleus as deep as possible. Tip number 4, a phaco power of 70 to 80% is good to go. Tip number 5, bury your phaco tip to around 60 or 70% depth of the nucleus. As you can see, even this hard nucleus can be chopped right away without any trenching, without any sculpting. Once you get in the habit of trenching and sculpting and divide and conquer, there's a lot of time and a learning curve required to get used to the modified chops and modified direct chops that I'm doing right here. So it is better that in your early days you start from learning the most efficient technique that there is. I'm even chopping these nuclei, these quadrants, into even smaller pieces, as you can see. And I'll try to bring one piece up. And yes, I am, just look at that color. Just look at that Coca-Cola brownish, dark, blackish hues in that endonucleus. These bubbles can make situations difficult, but nevertheless you have to be spearheaded. You have to be strong in your mind to go ahead and chop that nucleus. And yes, one quadrant is out in the same time as I complete one case. Never forget to viscoat the endothelium repeatedly. Every cell of human body is precious. My gurus, my teachers used to say, you should consider human tissue like a human tissue. This is not a prosthetic eye that you are operating. This is a real patient eye. Save as much patient tissue as possible, especially in cases like these where collateral damage is inevitable. You'd always take the use of viscoats and mydriatics. If you happen to see the pupil constricting, that can make cases difficult really fast. As you can see, I'm coating the endothelium with fresh visco after every quadrant. Some of the surgeons and colleagues are that they make across. Yes, I have zoomed the view for you to all look and just feel amazed at what modern science and technology and surgery can do. You can see half of the nucleus is gone, and you see that beautiful sunset orange glow in the half that I have taken out, and the other half is full of this dirty brown sclerosed human crystalline lens. Yes, I am cautious. Don't worry about these lingering fibers that are making chopping difficult for me. This sharp chopper can be scary for new surgeons, but don't worry. Once you have a hold of this chopper, you'll be used to it in no time. Experience teaches you a lot, is a great teacher. I hope you learn from my videos, because I've done every complication that you can think of. But you should always get up after every failure. You have to. And yes, it's so satisfying that you've taken the whole nucleus out. An intact PC stares at you, minimal cortex is left. I'm going to grab my I&A, the most efficient form of irrigation aspiration, the bimanual I&A. It gives you access of 360 degrees of the bag and the cortex. Cortical cleanup takes around 20 to 30 seconds, a good cortical cleanup. The patient had a vision of hand movement preoperatively, and he had a post-operative vision of day 7, 6x6. Yes, I won't deny the fact that he had minimal corneal edema, because I was using continuous phaco energy at 80% power, longitudinal mode on an Oatley machine. But yes, we gave him some hyperosmolar agents in the post-operative time, and the patient had a beautiful outcome. That was a fun case, I think, and as you can just go and read the title, yes, it can be really hard for you guys in your initial days, but don't give up. That's all from my side. I hope you like my videos. Kindly like, share, and subscribe. Thank you.